Thank you very much, Pascal. Lots to think about and chew on and perhaps debate in the discussion. Our next speaker is our patient, David Andrews. David was a college professor in New Hampshire for 32 years in cognitive neuroscience, and upon retiring moved to South Carolina. Due to an underlying neurologic disorder, he had many interactions with the healthcare system, the Medical College of Georgia, and it's now Georgia Regents University. After some less than satisfactory care, he complained, actually, he prefers it to be called constructively weighed in, constructive criticism, and as is often with our approach at Virginia Mason, he was co-opted to be a patient advisor. Since that time, he's been involved in an advisory role in nearly everything the hospital does, from very specific initiatives like redesigning the patient bill, helping to select new beds, and designing new facilities. His work is extended into local, regional, national, and international presentations on training on patient and family-centered care. So we're really thrilled to have David here. He's also been a reviewer for Patient-Centered Outcomes Research Institute, their research grant proposals, and is a PCORI ambassador. So David, thank you for sharing your perspectives with us this morning.
You can forget all that stuff he said. I'm just a patient for purposes of today's event. One of the things that's rather daunting about this is I am the patient here. Not that all the rest of you aren't patients on occasion, but it's the only reason I'm here. So I'm going to try, though I'll use personal stories and perspectives, I'm going to try and project myself as the generic patient in this whole discussion. And as you'll see, some of my perspective is, to be more precise, qualitative or squishy compared to the rest of. Little further. This good? Is this good? Okay. So I saw that this was about engineering, and I have a fairly vivid imagination with a somewhat whimsical side to it, and I immediately imagined myself as a widget being processed through your elegantly designed system with great conveyors and wonderful queuing theory and supply systems and matching of supply and demand and all of that, but somehow I was still the widget. Have you ever tried to visually image what a widget looks like? Doesn't work. In any event, I must say I'm a fan of engineering, and I'm also a big fan of systems design, but I'm a patient too. And I think there's a human side to this, which I'm going to try and talk some about, that's an important part that's often left out of the discussion when you get busy doing systems design and engineering. So I'm going to give a couple examples of some things to try and make a point up front. One of them relates to some things that were mentioned in my bio. When I moved to South Carolina, I took all my health care to what was then Medical College of Georgia, and I visited a number of different doctors. My average wait time, after I believe it was about 6 visits, was over an hour. That's between when my appointment was and when somebody saw me. And not only that, nobody ever said anything to me during any of that time. It was just, be happy to be here, sit and wait, and the great man will get to you eventually. After a while, I decided that I would point out that there was an issue here. As they called me, and when people call you in, they say, "How are you?" They don't really want to know the answer, and at which point I would say, "Fine," which is the answer they wanted. And by the way, it seemed like it was an awfully long wait today. And the response I got from everyone, every single person without exception, was a minor variation of the same response, which was, "We're busy." At which point I had a minor epiphany. I said, this is all about them. None of this is about me. And that's a real problem. And I think that's one of the things that's important for those of you engaged in this work to keep in mind. It's not all about you. It's not all about the people who I like to think of as on the other side of the check-in desk. It's also about those of us who are on the front side of the check-in desk and what we think and experience. So one perspective on all of this is I'll pose as a rhetorical question. How much of the issue is the wait, and how much is the communication about the wait? And to answer that, I'm going to give you another example, again, a personal one, but I think it illustrates a number of issues fairly nicely. I was at a new doctor, and I had a wait that was over 2 hours. Now you think 2 hours is a long time and everybody'd be unhappy, but during that 2-hour period, twice a woman came out. She says, "Hi, my name is so-and-so. I'm the nurse manager of this facility, and we're really far behind today, and we're very sorry for any inconvenience this causes you. We're way behind, and here's why." She told us why they were behind today. "We're working as fast as we possibly can to get caught up with everyone. If you would like to avoid waiting further and reschedule an appointment, please come up to the desk and we'll schedule you for the first available time. Or if you would prefer to go someplace and do something else while you wait, leave us your cell phone number and we will call you when we're getting close to ready for you." Now, most of you in the room are old enough to remember Mikey in the ads, Mikey who hated everything. There are Mikeys and they'll hate everything, and it doesn't matter what you do. Everybody, and there were about 20 people in the waiting room at that point, everybody was good with that. It was fine. They understood what the problem was. It was clear that she cared about your inconvenience, and she provided you with some alternatives, some other things that you could do in order to deal with the wait time. So often it's the communication. I think that example captures some of the important issues of how you might communicate. As much as it is the wait. And that can include the wait in making an appointment as well, but I'll get to that a bit later. The other thing is that I think we have to consider the context with all of these things. I appreciate the concern that you expressed earlier about having a generalized scheduling system, an overall system, but I think there are also contextual issues that can matter a great deal in how a system works. They may be cultural issues. Is Bedford-Stuyvesant and McAllen, Texas, and Fairfield County, Connecticut, are they all going to have the same kind of customers with the same concerns and the same issues? Probably not. Is the issue the same as the flow through from an ED department to hospitalization as it is with, say, a OBGYN or a dermatology clinic? There's some very different issues there. And what do you do if you have a department that happens to have a whole collection of 600-pound gorilla physicians who are going to do what they want to do the way they want to do it no matter what? There are contextual issues, and they matter a great deal. In my institution, a lot of the progress that we've made in terms of scheduling is progress that happened locally, not institutionally, but locally. In fact, one of the major things that moved the process ahead was the fact that a lot of patients in a lot of areas on our patient advisory group said, we need to do something about these long wait times. And when I say wait time, I mean both to make an appointment, also to get in after you're there for your appointment. Patients were concerned about that. They wanted something to happen. So what happened was, to use an old and often abused term, consciousness was raised about the issue, and people began to say, maybe we should begin to think about this and what we're going to do about it. That was a major issue in terms of making progress, because now we know the patient and the patient's time matter, and we're going to try and do some things to address the patient time. There are other things that patients have been involved in promoting, and I think the important message in all of this is that patients have a view of this that's very different, but also very insightful frequently, and if you don't listen to the patient's voice, the odds are very good that you're going to design a great system for somebody or other, but it may not be so great for the patients. So let me, in order to be reasonably brief here and try and keep in my 10-minute limit, summarize a bit of what I think are major issues that have to be considered in all of this. One of the issues is the attitudinal issue, the you guys are more important than we guys issue. I think that issue often is a prelude to making any real serious progress with the issue in general. Secondly, communication is a terribly important part of this. We're human beings. We like to feel appreciated. We like to feel that somebody respects us and is going to treat us with some kind of dignity and move us through the system in an efficient way. A third is I think you have to pay attention to the context, the patient context. There's diversity issues in the patients, but also the institutional context. Who are the people? What's the nature of the practice? What are the special issues that exist in that practice that have to be a part of the consideration of whether or not things work? And perhaps most importantly, anything you do is only going to be effective if patients are involved in making the system, designing it, helping to implement it. I could give you more examples than we have time for of instances where patients, many of whom don't have much education, have had tremendous insights that have been very helpful in solving important problems about scheduling and wait times. So you need to have patient advisory groups or have patients involved in all the committees that you're working on, because patients will bring something to the table even if they don't open their mouth. It's a human face that's there that says this is about serving them as well as it is about serving you. So I'll stop at that point and look forward to our discussion later.